Okay, great. I think we'll go ahead and begin. My name is Priya Jaisingani. I'm endocrine obesity medicine at NYU. I just want to welcome everyone to the Tri-State Obesity Society lecture series called the Roots Curriculum, which we're going to be having this fall into the winter. I just want to say thank you for attending. Make sure you visit the website, tristateobesitysociety.org. You can register as a member and find more information about upcoming events, webinars, lectures. I just want to introduce our first speaker for our Roots Curriculum series, Dr. Eugene Lucas. He completed his internal medicine residency at Hofstra Northwell, and he also completed fellowships in clinical informatics at Columbia NYP and obesity medicine at Weill Cornell. He's currently at NYP, Columbia, and Cornell, serving as an assistant medical director of clinical information services and also an assistant professor of medicine at Weill Cornell in the Comprehensive Weight Control Center. And I'm really excited for him to give our first lecture today to kick off this series. So without further ado, I'll hand it over to him.
Thanks so much, Priya, and thanks everyone for attending. Really happy to have a forum to present.
We can't hear you, Eugene. Oh, now we can hear you. Okay.
Now you can hear me. Okay. Well, thanks for the introduction, Priya, and thank you for everyone for attending. I'm really excited to have a forum to discuss some of these topics. So let me share my screen. All right. Assuming everyone can see this, let me get this thing out of the way. Okay. So today we're going to talk about lean mass as part of an obesity medicine treatment plan, and specifically strategies to assess for lean mass and then strategies to develop and maintain it. All right, so as an introduction, we know about the benefits for patients that have weight issues associated with weight loss, but it seems like there's been less attention paid to the connection between lean mass and mortality. So we know all patients will lose lean mass with age, and that weight loss puts the lean mass at increased risk for losses, and up to like 20 to 30% of total weight loss is estimated to come from lean mass. So in terms of body composition assessments, we have a number of different ways to do these assessments. Some are more accurate than others, and we'll discuss those as we move forward in the talk. But because they're not in the guidelines yet, I think it's warranted to be worried that these are being underutilized, and I think we're missing opportunities to optimize patient outcomes as a result. So this is kind of just a summary slide, and we'll cover everything, numerous slides for each topic here, but just a summary here. So the RDA for protein intake has been well studied, and we know that that 0.8 grams of protein per kilogram of body weight per day, patients will lose lean mass as a result of using that as an upper limit. And not that it's recommended as an upper limit, but it kind of gives patients a number to aim for, and the data suggests that that's too low, certainly to develop muscle mass and even to maintain it. So yeah, we'll just jump into things in more detail now. So I wanted to start with talking about the obesity paradox, because this informs a lot of the talk. And so just to describe what the theory is, it describes the counterintuitive finding that aged, overweight, and obese individuals with a particular disease may have better outcomes than their normal weight or underweight counterparts. We have the citation there from Drame et al. An explanation that Drame uses and that other studies support is that in an acute event, that patients have, obese individuals have a better chance of survival because of their greater functional reserves. And here's an outline of what that curve looks like. So we see this is a graph of mortality and BMI, and as the BMIs go down, the mortality goes down up until this BMI level of 25, at which point the mortality starts to go back up. So to summarize some of the data that are supporting the obesity paradox, Drame et al. Had authored a systemic review, so I thought that was a good source to review as part of the presentation today. 58 studies were selected for assessment or analysis as part of their publication, and they had kind of commented on specific groups according to the meta-analysis. So to summarize, at high level, 75% of the studies of individuals with obesity that had or at BMI levels that had a medical, that had a medical condition documented. So 75% of those were in favor or in support of the obesity paradox versus 50% if the patients or the individuals in the study had no medical condition. And the studies that failed to show better survival included patients that were on average younger than those that supported the obesity paradox. So that's kind of what we would think about the data. However, there was a separate meta-analysis that was done by Flagel, and they looked at the BMI mortality situation across a wider range of age levels. And what they found was that there was a hazard ratio of 0.94, and this was for all individuals in the study. And I believe most of the studies still that were assessed by Flagel et al. Were still in patients that tended to be older, tended to be 65 and above, but they did have a few studies that were included where the ages were younger. So they did a sub-analysis, and they found a greater mortality benefit for patients that were greater than 65, so 0.9 versus 0.94. So again, that makes sense in line with the data that we have from Dre et al. So how does the obesity paradox relate to muscle mass? So there are like over 20 studies that investigate the obesity paradox through specific lenses, usually from the lens of different medical conditions like heart failure or cancer, these sorts of things. There's only one study that looked at it through the lens of muscle mass. And this is a study that was done by Abramowitz, and we'll cover that in a moment. But just to stay on topic with Drame's meta-analysis, they were aware of this. So they talked about that sarcopenia is a risk factor for death in patients with obesity and in general. And they did find that patients that or not Dram et al., but Tian found that patients with obesity and sarcopenia had a higher risk of death than individuals with obesity who did not have sarcopenia, which is, again, what we would expect. So this is the Tian study. So in patients that were 65 years or above, they found a prevalence of 0.8% of patients that had obesity and sarcopenia versus 11% of patients that had sarcopenia in all BMI categories. Another study by Chang et al. Selected 10 studies that investigated the relationship just between sarcopenia and mortality. And the hazard ratio there was 1.87 compared to individuals without sarcopenia. And they had used different definitions there. I think that was a summarized hazard ratio based on the 10 studies that they included in their analysis. So just to flag 1.87 as a hazard ratio with sarcopenia versus the 0.9 hazard ratio for the patients having a BMI greater than 25. So not that we're inducing sarcopenia on a regular basis through weight loss strategies, but it's still noteworthy to state that clearly how high the hazard ratio is for patients with low muscle mass. So given what we have here, it's possible that J curve would be modified if muscle mass were taken into account. And that is what the Abramowitz study did. So they used data from NHANES, and they looked at individuals who completed a DEXA scan with the goal to examine the effect on muscle mass. There's a absent word there on the BMI mortality relationship. So a lot of individuals in the study, 11,000, there's the distribution according to ethnicity, and they did look at it through specific factors. So presence or absence of sarcopenia. I mean, and this is noteworthy because it was just a binary classification. So they're looking at, is someone's muscle mass so low that they meet criteria for sarcopenia, or is it, or do those patients not have sarcopenia? So we didn't look at a granular analysis of the benefits of the muscle mass in terms of the hazard ratio, but they did assess it in a different way. So I'll come to that in a moment. Lean mass, just to mention, states is a commonly accepted proxy for muscle mass. So lean mass is different than fat-free mass in that fat-free mass includes bone in the assessment, whereas lean mass excludes bone and therefore is a little bit of a better proxy. Low muscle mass was defined using the conventional definition for sarcopenia within ASMI, and that's defined there, the appendicular skeletal mass index of less than 5.45 kilograms per meter squared in women and less than 7.26 kilograms per meter squared in men. The appendicular skeletal mass is the mass in the arms and the legs in kilograms divided by the height in meters squared. They also assess for the presence or absence of chronic disease and age greater than or less than 60. So looking at, I kind of use, this is data from NHANES, specifically just with normative data for the appendicular lean mass index. So what I'm highlighting here is that for males, the average muscle mass there was 7.79, and that is at the 50th percentile for an 80-year-old man. So that is quite low when we're looking at ages that are younger than that. So it's possible that there could be, you know, a greater mortality benefit if we had looked at or specified different muscle mass amount or different categories of the appendicular lean mass index according to higher amounts of muscle mass. And we did see a modification of the J curve as a result of the Abramowitz study. So this is the curve without muscle mass being taken into account, and this is the curve when muscle mass was taken into account. So this is one of the tables or figures from their study, and this is looking at body mass index and hazard ratio across BMI levels according to the criteria listed up top. So when we adjust for muscle mass, the lowest mortality, lowest hazard ratio was found to be 0.91. Now, the line does cross 1, so the confidence interval crossed 1. Nevertheless, you can see a very prominent trend there, despite the fact that the confidence interval did cross 1. And it should be noted that well, I'll mention this in a different slide about some limitations of the study and the way that it was difficult to, it's always difficult to achieve statistical significance, but in some of the subcategories, there are only about 4,000 patients in each of those categories. So the fact that even then we did see this trend being as evident as it is I think supportive of the fact that there is a signal there, and it's possible that it would have achieved statistical significance if they were able to have greater numbers of patients. This is in the supplementary section of the Abramowitz study. So these are all the categories. I'm not going to go through all of them. But if we look specifically at the age greater than 60 with the muscle mass being taken into account, according to BMI, again, the lowest hazard ratio was found at the BMI range of 22 to 25. And then this category, this column over here is the appendicular skeletal mass index per 1 kilogram in meters squared. So what this is showing is that in the population, someone who has one point higher on the ASMI has a 11% reduced hazard ratio, or 11% reduced risk of mortality. And I actually spoke to Abramowitz to kind of get a little bit more clarification here. And that's kind of the summary of the conversation. But I also asked, you know, if someone was 2 points higher, would that be 22%? And he said it's more complicated from a statistical perspective, but so it would be a little bit less than 22 generally. But this is just highlighting that how strong the benefits are from a mortality perspective with increases in the ASMI. And this category did reach statistical significance. All right, we'll go to the next slide. Okay, so more on lean mass and mortality. So I'm not sure if I'm going to pronounce this correctly. Srikanthan. So they looked at, they didn't look at this through the lens of BMI. They just looked at muscle mass and all-cause mortality. And they again used NHANES data, but in this case they used bioelectrical impedance measurements. We'll have more on that in a later slide, but the bioelectrical impedance measurements, they're less accurate than the DEXA scan. They tend to underestimate muscle mass and tend to overestimate fat mass. So yeah, I mentioned about the BIA there, and then the calculation was, so this is not the appendicular lean mass index. This is the total lean mass divided by height in meters squared. The median length in follow-up was 13.2 patient years. And then here are the results. I kind of modified the table a little bit so that the muscle mass indices were displayed a little bit more clearly. And the highlight from this table, if we're looking on the left side here, absolute rate so this is the rate of death per 10,000 patient months or person months. So if we look at the lowest quartile, so these are 25th percentile or below, those patients lived on average 15.1 months less than patients who are at the 50th percentile or above. And that's kind of the way I talk about this with patients, is that we're not trying to get you to be in the 90th percentile in terms of muscle mass in order to see a benefit. We just have to get you north of 50 and then try to keep you there over time and concurrent with weight loss efforts. And these this study, these analyses did reach statistical significance, as you can see by the p-values. Okay, so lean mass in relation to total weight loss. So I kind of mentioned up front about the 20 to 30% loss of lean mass relative to total body weight loss. So we're going to go through some 2 studies on bariatric surgery patients, and then 1 study on medication-supported weight loss patients. So Carrasco et al. Looked at patients who had undergone a Roux-en-Y gastric bypass. They used a different method for body composition, and they found that and they also didn't look at lean mass, rather they looked at the fat-free mass. And again, that includes bone, so less of a specific proxy for muscle mass, but still the results are significant there with a 23.3% loss relative to total weight loss. And of note, the protein intake here is even below the RDA. So anyone would be losing muscle mass with a protein intake there, and maybe even more so in patients that have had bariatric surgery. A separate study by Martinez et al. Looked at 85 individuals with class 3 obesity who underwent bariatric surgery. I'm forgetting which variety it was for that group, and they found 21% loss in terms of fat-free mass relative to the total weight loss. And I guess a couple of different bariatric surgery techniques were done, and that was independent of the bariatric surgery technique itself or the protein metabolism. I didn't want to go into the protein metabolism there. It's not as easy to just about protein intake. They looked at specific lab metrics there. Okay, so now for the study from Wildling, who did an exploratory analysis on data from the STEP 1 trial. And that was, hopefully, as we all know, was looking at semaglutide in patients with overweight or obesity. They did body compositions via DEXA scan. We know that the overall weight loss result was about 15% over the 68-week period with escalating doses. Patients lost, so in the study specifically, they mentioned 9.7% lean mass, but I had to do my own calculations to get more specific numbers, and I think those will be on the next slide. So if we look at the initial lean mass in kilograms was 98.4 kilograms, and this was, let me see here. I looked at, let me see here what I did. So total weight loss in kilograms was the 15%. And then if 9.71 was the loss of lean mass, then I looked at just the number there, because what they gave is the change in lean mass rather than the change in lean mass over the change in total weight. And if we look at this study, it was even a higher rate of lean mass loss, almost 35%. Okay, now moving on to another topic, protein intake and lean mass. So we have numerous studies showing that the RDA is insufficient to develop muscle mass, and usually patients are losing muscle mass with that protein goal as a higher limit. So I just wanted to take a step back and go through a little bit more information about some of the dietary recommendations and terminology here. So we have the ERA. The recommendation there is 0.66, and that's defined as from the vantage point of the amino acid requirements. And then we have the RDA, which is the 0.8, and that's thought to be the minimum amount to meet amino acid requirements, and also to establish nitrogen balance, and theoretically to prevent muscle loss for 97% of the population. And then the WHO has a similar recommendation from their protein intake goal. And then, so this is notes from Carbone et al., who noted that it's often incorrectly applied when used as a definition of recommended intake rather than its true designation as the required minimum intake. Even so, I think the minimum should probably be higher based on the data that we have. And then Carbone mentioning that the misapplication is problematic and disadvantageous for those who would necessitate higher protein needs. Study by Barr et al. Summarized results from various studies on protein intake and health risks, specifically in patients 65 or years or above. And then, so we're going to have 2 slides on this. And the first slide is going to be on this first section that they had, which is in healthy older adults. And then we'll get to older adults with chronic and acute conditions thereafter. So from the healthy older adult section, it demonstrated that over 3 years among 2,000-ish individuals that were between 70 and 79, that the subgroup of individuals who achieved protein intake of 1.1 lost 40% less lean mass than the subgroup who consumed 0.7, which is the lowest quartile in that study. Another study mentioned by Bauer is that of Campbell that found that consuming the RDA resulted in the loss of mid-thigh muscle area over even a 14-week period. So they didn't do body composition, but they used the thigh circumference as a proxy for it and did find decreases. If we look at adults with acute and chronic conditions, so they had a number of different categories here. We won't go through all of them: frailty, hip fracture, osteoporosis, stroke, pressure ulcers, COPD, cardiac disease, diabetes specifically with kidney disease, and then kidney disease on its own. And based on their review, they were recommending that the protein goal should be 1.2 to 1.5 to promote optimal health in those populations. And then just a summary, individuals who are achieving weight loss are at increased risk for losing lean mass, and therefore we need a higher protein intake than what is referenced by the RDA. Just from a clinical pearl here, we have a number of low calorie and high protein content shakes that exist. They're generally affordable. They're generally well tolerated. I tell patients to view these as a formal prescription because I do think it is providing that level of benefit. There's a small number of patients that I just couldn't find the right protein shake for them. I tell them it's never supposed to taste like heaven or like a milkshake, but generally we should be able to find something that's tolerable and that they're not dreading using it. And I also recommend that they just mix them with water. So again, the taste content of the original shake is important because we don't want to be adding more calories to it if we can help it, since we're going to be using the protein shakes to try to promote caloric reduction and then thereby to facilitate muscle or weight loss. And then I also just mentioned that, like, regardless of how they do the protein shake, it's going to be helping with muscle mass. But they can do it in a way where it's helping to reduce calories. And my recommendation there is for them to use it as pre-meal supplementation. So drink the protein shake just a couple of minutes before the meal. A little bit of a tangent here on the study on Plenity, which was like a medical device that patients swallow and it expands in their stomach and kind of promotes fullness. The placebo group in that study drank 16 ounces of water like 2 or 3 times a day before their meals. And the placebo group lost 4% of their body weight. So I'll share that with patients usually and say, we're not doing exactly that. We're doing something different. And I think it's better, about 8 ounces of water, but in that water is 25 grams of protein. So more evidence on the benefits of high protein diets or weight loss, weight management regimen. So study by Leedy et al. Performed a literature review on clinical outcomes after long-term high protein diets. So their diet with 30% protein, or that was a high protein compared with 15. I'm sorry, diets with 30% protein were compared to 15% were associated with decreased energy intake. We also know there's a hormonal effect. So PYY and GLP-1 are stimulated by ingestion of dietary components, particularly dietary protein. And they noted that there is a dose-dependent relationship there. And then at similar energy deficits, the higher protein diets lead to greater weight loss, greater fat loss, and better preservation of lean mass compared with lower protein diets in patients with a BMI greater than 7. And also in patients with diabetes, they found greater weight loss, greater A1C reduction, and greater BP reduction. There were 12-month studies that looked at like this 25% intake of protein for the high protein diet. I don't think it was commented on the specific amount of protein there. So it's hard to evaluate it through the lens of the other recommendations of the 1.2 to 1.5. They also noted a time treatment and time interaction after the weight loss phase. well, I forget exactly what I'm trying to say here in this study, that I think there is just greater weight loss with the higher protein. And the results there were statistically significant from Soen and et al. Okay. I did want to mention some of the limitations that Lady and mentioned in their meta-analysis. So there's the idea of this like protein threshold, which is the amount theorized to be necessary to stimulate muscle protein synthesis. So this could play a role if the patients are having a high protein diet, but it's spaced out in such a way where they're never having that threshold occurring in the context of a meal. So it has to occur in a short time period. And this is part of the reason why whey protein shakes are better than protein shakes of other sources, specifically for muscle mass development, because whey protein shakes, the protein content is more bioavailable, and it's also faster absorbed relative to casein. I'm not saying casein is bad, but if we're looking specifically to be using protein shakes to promote muscle mass, the whey is better from that sense. Lady et al. Also noted variability in dropout rates, which can contribute to bias. And then there was poor compliance with most of the diets, regardless of in most of the studies that were done. They also noted that the higher protein diet groups did reduce their protein content throughout the study, and then lower protein diet groups increased their protein, and then returning back to their habitual protein intakes thereafter. Okay, so does protein supplementation help with achieving weight loss? So there's a lot of studies that have been done on this, and some of them are, again, for various reasons as part of the studies, it's hard to evaluate whether or not the protein diet was high enough to really see the signal that we would expect to see. Kajolbeck performed a randomized controlled double-blind trial. This was 220 patients between ages of 18 and 60 with BMI 27 to 40 for 24 weeks. They did 3 meals per day, and then they had 3 types of isocaloric protein supplements, and they just wrote that it was consumed as part of the 3 meals. So it's hard to know, was that meal replacement, was that before the meal, could it have been after the meal? We don't really have that information. This is some of the information on the low carb diet that they were having from within the trial, and then the protein supplement details. So each shake there contained 27 grams of protein. So they did not see a difference, but we have limitations there in terms of, we don't know how much protein in terms of a amount of grams of protein per kilogram of body weight per day that those patients were using. And then, yeah, I mentioned this already about it's not clear exactly how they were incorporating them into the day. And then we don't know about the total amount of protein that they were consuming relative to their individual total body weights. Another study also showing that, like, also saying that they didn't find an effect on high protein diets. So their goal was the 1.2. So that is like thought to be the minimum there. But again, it may be the case that individuals, as people get older, it is known that a greater amount of protein is needed. I think it's reasonable to start there, but even so, they also did not do body composition assessments. So we don't have, I don't think this study in particular is strong enough to make the statement that they made that whey protein during weight loss has no clinical therapeutic benefit. I mean, they're mentioning specifically it's in postmenopausal women, and there's also data that women might need more protein than men. All right, next topic is strength training. So a review by Westcott et al. Noted the following, that 3 to 8% of muscle mass is lost per decade. I kind of tracked this citation for this through like 3 different studies, and I couldn't even find clarity on where this comment came from, because it wasn't included in even what I thought was the original study. Nevertheless, it's commonly reported. I mean, it's plausible, but I wouldn't stand strongly behind that number there. But with regard to the resistance training, we know that resistance training may increase lean weight by 1.4 kilograms over the course of even 10 weeks, increases resting metabolic rate, and reduces fat weight by the 1.8 kilograms. It's hard to, I mean, we kind of all intuitively know the benefits of greater muscle mass, improved physical performance, movement control, walking speed, functional independence, cognitive ability, self-esteem, also lower risk of falls and fractures. And the muscle mass or higher amounts of muscle mass may assist in prevention and management of type 2 diabetes by decreasing visceral fat, reducing A1C, and then increasing the glucose transporter type 4, and thereby improving insulin sensitivity. The lean mass may also enhance cardiovascular health by reducing blood pressure, decreasing LDL cholesterol, triglycerides, and increasing HDL cholesterol. May also promote bone development, with studies showing 1 to 3% increases in bone mineral density. So if we're going to recommend like strength training to our patients, like how can we be more specific in a way that's evidence-based? So this another study by Westcott, they looked at different different frequency amounts of strength training. 1, 2, and 3 sessions per week over 10 weeks was what they studied. These sessions included 20 minutes of aerobic activity 3 times a week, and then 1 set of 8 to 10 resistance exercises with 8 to 12 repetitions each. That's a good number to remember. I mentioned that to patients, that if you're getting above 12, that means you're getting stronger. It means your muscles might be getting bored, and it means if you don't go up, you're kind of missing out on some of the higher benefits from. I kind of usually phrase it as return on investment, because they're putting the work in, they're going to the gym, they're doing the exercises, but if they're doing 15 repetitions, we know that they're not maximizing the muscle growth that would occur. And then for the patients that are going to the gym frequently, but they're not keeping an eye on their protein intake, they're also potentially hampering the amount of benefit that they're deriving from their efforts. The population in this group was adults aged 21 to 80 with a mean age of 55. So the results I put in a table, I think there's I'm going to show other results or comment on the results in a second. But if we look even at the once a week group, they had a benefit in terms of lean mass with a 0.33 believe kilogram increase. Not dramatic, but it's still helpful to know that they were increasing their lean mass as a result of even 1 day a week. But you did see greater benefit at twice a week. And interestingly, there was no additional benefit by doing a 3rd session per week. I think, bodybuilders would take issue with that, but that's what they found, at least in this particular study. I think these individuals had been previously like untrained. So I think there's a lower threshold of effort required to see benefit in someone that hasn't been training prior to study onset. So just the summary here, while larger training doses produce greater fat mass, 3 days a week was better than 1 or 2. The changes in lean mass were no different between 2 and 3. So these findings suggest single sets of moderate to high load resistance training performed with low frequencies, minimum twice a week, can improve muscle mass, but they did not specifically assess for strength or muscle power as part of that study. And yeah, just to note, these results did reach statistical significance. I don't know why I can't see which one A, B, and C pertain to, but we can come back to that if anyone has questions. And then this is going to be probably small to see. It's just a graphical representation of kind of what we talked about already with the lean mass relative to the loss of fat mass over the course of that study period with regard to how many days a week they were doing the training. Okay, so we've been talking for a while about the benefits of lean mass, and now we should talk about how to do these assessments. So the DEXA scan, I mentioned this up front, is the most accurate. Gold standard for assessing body composition. There is a radiation dose, but the dose is very, very low. So the upper limit, the data suggests the upper limit is 10 microsieverts. And if we look at, all right, what's the recommended amount by the clinical sources in this area in radiology? So they're saying average background radiation is 3,000 microsieverts, and that they're recommending a dose limit of 1,000 microsieverts from medical sources of radiation for the general population. So about 1/100th of the annual dose. So generally that's not a concern. Nevertheless, some patients may have preferences otherwise, and we'll talk about what to do in those scenarios. What about cost? So I practice at Cornell. I order it at Cornell. Coverage is about 50-50. I think at Cornell, the cost is about $300 out of pocket. So I've since found a site in the city where they offer it for a cheaper price. At that site, which is Cenegenics, if the patient buys 2 scans, the total cost is $250. So the individual cost is $125. And I often recommend that option because then patients will put one in their pocket to do again next year to keep doing the tracking on an annual basis. I just estimated $200. I didn't really there are a couple sites where that's the cost. So you should be able to find it for around that much or cheaper in some cases. All right, next option, if the DEXA scan either not available from cost or radiation perspective, this is like a more sophisticated version of doing a bioelectrical impedance analysis. So this assesses the body in 5 cylinders using multiple frequencies. The number of frequencies used seems to be the primary determinant in terms of the cost and potentially the accuracy of these machines. So I'm skipping ahead of myself. So let me just go to the next bullet point. So compared with the DEXA scan, the in-body scans were producing significantly lower values for body fat and higher values for fat mass relative to DEXA scans. Additional statistical data there, and that's a study from ESCO. So of note, I mean, it's kind of it was a little difficult finding data that specifically did this comparison in a population that would be more generalizable. This was the best I could do, 45 female athletes with an average age of 21. So my apologies there, but limitations exist. All right, next option. So bioelectrical impedance consumer scales. So generally they use a single frequency mechanism and they cost around $20. After I wrote that, I just looked up other scale options. So there are multi-frequency scales that can cost, some are 100, some are 200. It's not clear to me how much more accurate those are. But I think these have a role, and certainly this is a good way to, it takes time for someone to schedule a DEXA scan, carve out time to actually get it performed. So it's a good idea. It's not a lot less difficult to at least buy one of these scales and get an initial assessment. I still would encourage them to get something more sophisticated and accurate, like an in-body or a DEXA scan. But sometimes things happen and those things are not going to get done. And it'd be better to at least capture some of the body composition data at the onset of the weight management or weight loss program. Study by Nickerson compared DEXA scan data for body composition with single frequency BIA. This was in a study of 28 men and 45 women with BMI average of 26 and average age of 22. So the BIA values were significantly different for all comparisons. And that achieved statistical significance range of -0.8 up to 5.9. So that can have a significant impact in doing the appendicular lean mass index. Again, this is fat-free mass, so it's not the same, but just highlighting that there can be variations there. These scales will typically provide a lean mass or muscle mass estimate, but again, it's typically over. Let's see. I forget, actually. It's on the next slide. A lot of data that I've been combing through over the past couple of days, so forgive me for that. In women in that study, the results were also statistically different for all comparisons relative to DEXA. Did I have another? Yeah, all right, just skipping over that. Okay, so Ryder et al. Compared different body composition mortalities. They had 148 patients age greater than 70 with a BMI of 27. So these are just a whole bunch of different BIA methods. They use different calculations for each of these to try to get a better estimate. And there's still a pretty wide variation in terms of, I mean, everybody has a different, there's no standardization for this term. Appendicular skeletal muscle mass, I guess is what they're going for there. That's probably the total muscle mass. This is way too high for that to be an ALMI. So that's the total muscle mass over the height in meters squared. And again, quite a bit of variation across men and women. And then on the next slide, I'll kind of have a little bit, just 2 more studies to go over, and then we'll leave this topic. So Patty Johns did a study in DEXA with multi-frequency and single-frequency BIAs. 43 men in this study with a BMI range of 28 to 43 and average being 34. So if we look at DEXA for fat mass, the numbers are pretty different. This is a multi-frequency, so this is why I was like, it's hard to know if the multi-frequency ones are more accurate, because this one, the single frequency, more closely aligned with the DEXA than did the multiple frequency, and that was across all categories. Which, yeah, I'm not sure what explains that. So I wouldn't have patients go out and buy a multi-frequency scale to think that it's going to be more accurate. The other thing, though, is that this is a more expensive single frequency because it's the I think it's the same device that does the multi-frequency. So just mentioning that aspect as well. And this was so this is where I'll clarify the effect on lean mass and fat-free mass. Stoke-Losa did a review of 12 studies on the pretty much similar topic to what we mentioned over here. This was relative to DEXA scan. So if we look at fat mass is an underestimate, and then the fat-free mass is an overestimate. So they look like they have less fat and more muscle than is actually the case when using the BIA method. All right, so we've reached the end here, presentation summary. So given the connection between lean mass and mortality and the danger of lean mass loss as a result of weight loss, in my opinion, standard of care for weight management should include a baseline body composition assessment with annual assessments thereafter. Ideally, this would occur, soon or pretty much at onset of the treatment plan, or hopefully soon after. And I mentioned this to patients, like we know that lean mass has a connection with mortality. We know we're putting your lean mass at increased risk by trying to facilitate weight loss. So therefore, if someone's lean mass is low, that's something that we should know about. That's something that we should do something about. And if we find low muscle mass, the strength of those recommendations for adequate protein intake and strength training, they can't be understated, in my opinion. So while a DEXA-based body composition scan is most accurate, the BIA is a reasonable alternative for people with concerns for cost or radiation. I think it's reasonable to set the lean mass at the 50th percentile for normative data and that's referenced by the Srikanthan study, or the data from the NHANES database. The NHANES database, and I'll cover this I actually have two or three hidden slides to get through that I forgot about, but that's just going to be me kind of going through a little bit more about how to have that discussion with patients with their body composition results. Again, part of the recommendations, patients should be informed of the risks of lean mass as a result of weight loss, and they should receive education on strategies to preserve and increase lean mass as a result of weight management plans. I mean, just to take a step back here. So, I mean, this whole field of medicine for decades, like we weren't really able to produce significant amount of weight loss generally for patients. So it makes sense that when medications that were more effective, that we're thrilled just to see some weight loss occurring. But because we know now that lean mass is going to drop as a result, it is possible that the benefits of any amount of weight loss that they achieve, that those benefits eclipse the negative effects that can occur from the loss of lean muscle mass. But that's a sacrifice that we don't have to make if we have this discussion, if patients do try to adopt some of these strategies. Minimum protein intake should be familiar to everyone at this point, 1.2 to 1.5, and then noting that more should be recommended with age. I didn't mention this here, but I do want to take a second to comment on it. So there is data suggesting that higher protein intakes may have adverse effects in patients that have chronic kidney disease. Actually, the recommendation is for higher protein intake once they're on dialysis, but up until that point, I think a lower protein goal is generally what's recommended. The data is somewhat mixed. So some studies find that does increase the rate of declines in GFR, and other studies didn't really see that to the same extent. But I generally don't want to encourage patients to do that just because of the potential for harm in that scenario. So that's the one exception for the most part to the protein goal intakes. There's also some data in patients that have liver disease that they should also have a modified or reduced protein intake recommendation. All right, two hidden slides. So NHANES data, so that's here. If anyone wants to take a look, you kind of have to play around, not play around, but there's one or two extra clicks you have to do to find the data. It's like lower down on the website. I can show you if we have time, but I want to leave time for questions. I mentioned already about the calculation for the appendicular lean mass. So this is kind of what I've done with the data from NHANES. So I took screenshots, I assembled into a Word document. So now I have it, and I kind of have these individual screenshots now saved to make it more efficient when I'm going over this data with patients. And I'll show you more in a second, but I mean, you can message me and I'll send you the email. I'll send you an email with that Word document if that's easier. But the data's there if you want to just do it on your own. So this is kind of what I'll send to patients as a portal message. I'll take their muscle mass according to their age, and I'll plot it on this graph, and I'll say, and this is what is from NHANES. These are the 3rd percentile curve, 50th and 97th. And I did have a patient this past week that was very, like, she had sarcopenia. This is males, so the females is like maybe 1 to 1.5 points down, but her muscle mass was like 2.5. So I don't want to give too much information there, but I think it's that makes me nervous. It should make her nervous. That's something we really have to aggressively deal with to help prevent various risks. And we even have just a general overall mortality risk, it seems, that's associated with that degree of low muscle mass. What is this? I did the same. I guess I posted this same data point again here. This is there's visceral fat data that's also available if you wanted to cover that with patients. I also will go over the fat mass index. And I do see a conflict sometimes, not a conflict, but just some variation between their total fat mass index versus their visceral fat. So I've seen some patients whose total fat index, they were at like the 75th percentile, but the visceral fat was at like the 95th percentile. And that sometimes is informative when you're dealing with someone that has diabetes, and you can maybe point to the visceral fat as playing more of a driving role to, more difficult to control diabetes in that standpoint. References, there's a lot of pages of references. All right, that's everything. Is anyone still here?
That was fantastic, Dr. Lucas. Thank you so much for this lecture. It's so necessary, I feel like, to know where we're hearing these data points from, and you went through all of that extensively. And yes, all of us are still here. So it's absolutely fantastic. We do have some questions that have come up.
Wonderful.
So I'm just going to read them off through the chat, and then once we get through the questions that are there, if anyone wants to chime in, if we have enough time, we can go through them. All right. So first question is, if you have a patient who successfully lost weight using weight loss medication and is at a BMI less than 25 and is asking to continue their weight loss meds, how would you approach this given concern for further weight loss, muscle loss, and bone health?
Yeah, so that I'm pretty much requiring a body composition assessment in that scenario, because I don't, if we don't know where the muscle mass is, that Abramowitz data is not even applicable, or the Stricken-Fan data is not applicable, because I don't know where it is. So I want to, and I'll say that I'll share that with them, that some of the data did not reach full statistical significance, but we have a strong trend. We have all of this other data in support of the benefits of muscle mass, and in my opinion, I think we can aim for lower BMIs than 25, as long as muscle mass is preserved. And I would set that goal to be greater than 50. I'm not going to say that I'm going to withhold medication from them if they're not. If they haven't done it yet, if the BMI is like right there, but I'll generally not go up at that point until they're able to get that information done. And most people are understanding of that circumstance. I mean, I'm telling them that my notes are can be read by anyone in our system, and people are going to be wondering, what is Dr. Lucas doing with his patients, increasing the Wegovy dose when the BMI is already 24.9 or something, for example. But if in that circumstance I am going to go up, and I do know that the muscle mass is preserved, that's something that I will document specifically.
Okay. And the next question is, what machine are you using in practice to assess baseline body composition?
What machine? So generally it's the DEXA machine at Cornell, or the DEXA machine at Cenegenics. The one downside to the one at Cenegenics is that it doesn't do visceral fat. I mean, I'd love to have that data, but if someone has some financial limitations there, I don't think it's worth an extra $175 just to get that extra data point.
Okay. And what I think is really fantastic also, Dr. Lukes, that you included the out-of-pocket costs for patients. A lot of times we don't think about that.
Yeah.
And I think that's great that you put that in there. I do have a question for you. So
Uh,
I know, and I might have missed this, so just remind me, for strength training, oftentimes patients are asking for recommendations. And I know some of the studies you went over showed that, 8 major muscle groups, 2 sessions
mhm.
usually. How long are those sessions? Did they have any data in the studies about how long those sessions were?
It's going to depend on their breaks in between sets. So it's like 8 to 12 repetitions. That's going to take less than a minute per exercise, in most cases. So I think to maximize muscle mass, you want to wait maybe 2 to 3 minutes in between sets. But there's also an influence in terms of like how many sets are they doing. So if they do more sets quickly, they can overcome the limitation that would occur from them not taking the full 2 to 3 minute rest. I wish we had a gym attached to our clinic so we could have patients just go over and work with a personal trainer even for like 10, 15 minutes just to get a little bit of a more fundamental understanding. I mean, I have a lot of patients that don't really have any experience in this area, and the best I can do right now is to send them YouTube videos.
And I guess another question is, what do you how do you guide patients who are using BIA scales? A lot of them, do purchase them. So how do you because there's so many different varieties, types, how do you kind of keep track of that?
Yeah, I haven't had that many patients yet that are trying to share. I mean, I'll do the calculations when they share it with me. I mean, the in-body scan will allow you to do the appendicular lean mass assessment, but I still put a strong emphasis on doing the DEXA scan just to get a little, to feel more confident in the data, both for me and for the patient. And it doesn't seem like a super onerous request. It's to do that once a year, with the cost being what they are and with the benefit that we know is there. I mean, I don't know, maybe at some point I'll change my mind and I'll just be okay with the BIA data, just because of how more accessible it is. But I just, I think if that fat-free mass can be off by like 4 kilograms, I mean, that can have a pretty decent effect on what the appendicular lean mass index looks like. I think it'd be well within reason to make the argument that the difference is not high enough to warrant people doing the DEXA scan. So I'll continue to think through that, but with that just being the gold standard, and I mean, one way to handle it is just to share it in that way. This is the gold standard. It may not be the case that the data is so different that it really is going to change our plan of care for you. And you can choose to do the gold standard option, or you can choose to do something a little bit less sophisticated, and we'll still get useful data from that.
Absolutely. And we have another comment. It says, definitely an opportunity for further research, but there's at least one meta-analysis showing that the protein intake needed to increase lean mass while losing adipose mass is 2.3 to 3.1 grams per kilogram. The limitation from our perspective is that these are observational studies from bodybuilding, not the average obesity clinic patient. So that was one comment that was in the chat.
Yeah, I should review more bodybuilder studies. I think I would enjoy some of those reads. I mean, I'll bring that up to patients sometimes, just in terms of recommending that what they're doing is the best forms of exercise to maximize muscle mass. And for my patients that tell me they're doing strength training and that consists of Pilates, I'll ask them if they've ever seen a bodybuilder in a Pilates class. And everyone says no, and the bodybuilders, they only have so much time themselves, so they're doing exactly what they know to be the most effective exercises or routines in terms of their to maximize the return on investment, basically. And it's not that Pilates are bad, but we only have so many eggs that we can distribute throughout the week. And if you're putting 3 eggs in the Pilates basket and that's depriving someone from doing more focused strength training that is likely to have greater muscle mass benefit, then I'll generally recommend for them to shift some of that focus a little bit.
Okay, and then we have another question. What are some of your go-to low-calorie, high-protein shakes? This is so especially important for patients who are in the early post-operative period and unable to consume high quantities of food. So it's often difficult for them to be anywhere near their protein goals.
Yeah, I have a somewhat lengthy portal message template with all of those. I can name a couple off the top of my head. So NutriBio is one. I think that's for folks that are keep kosher, so that's an option there. Isopure is one that's usually my first recommendation just because I'm the most familiar with it. I'd probably say 15% of patients just hate the taste of that. I've had other patients be like, this is delicious. I'm happy with this. But there's a subset that don't like it as much. And within that subset, those patients that didn't like the Isopure, they were a lot happier with a different option called Unjury.
Great. This has been fantastic. Thank you so much, Dr. Lucas, for kicking off our Roots curriculum. To all our friends here, thank you so much for joining. Thank you for registering. You can always go to, again, tristateobesitysociety.org, register as a member of TriOS, and you'll have more information about when our upcoming events are, when our webinars are. And thank you so much for attending, everyone. See you next time.